Welcome back, everyone, and thank you for joining us on the second session of our three-part webinar series. For those who may be joining us for the first time, my name is Julio Robledo, and I'm the Quality Improvement and Reform Project Officer with the Primary Care Team at River North. In our first session yesterday, we explored the broader reform landscape and what current and upcoming Medicare changes mean for general practice. Tonight, we are moving on into a slightly different direction. We are from understanding reform to leveraging it. So we're going to be focusing on funding incentives, practical revenue opportunities that can strengthen practice sustainability. So in this session, we'll review a little bit of current Medicare, PIP, and blended payment models, as well as identifying underutilized billing and incentive opportunities. So we will finish with a Q&A, and our goal tonight is to help you better understand not just what funding is available, but how to optimize uptake and position your practice for a long-term viability. So before we begin, I would like to take a moment to acknowledge the traditional custodians of the land on which we meet today. We acknowledge the custodians across the land in which we meet today. We acknowledge the waterways, the land, the sky. We acknowledge their ancestors and elders and recognize those who continue to protect and promote Aboriginal and Torres Strait Islander knowledge. And we stand together in the past. Sorry, we acknowledge the past and stand together for our future. So before we begin, we have a few quick housekeeping reminders. This session is being recorded and will be shared with the registered participants. Usually we take a couple of weeks. Please submit your questions via the Q&A box down below. You can see there. We encourage you to have an active reflection mindset for this session, and we're going to have some interesting topics covering today. At the end of this session, there's going to be a survey popping up when we close it. So please help us respond that survey. This is the only way that we can know that we are kind of hitting the mark and that we're giving you content that is relevant for your practice. So I'd like to introduce one of the speakers tonight. Of course, if you were here today, you will have already met her. We have amazing Jane with us tonight to continue our three-part webinar series. She's an absolute expert in this arena. So please, Jane, take it away for us, and let's see what topics we have tonight.
All right, thanks so much, Julio. We'll jump straight in. Tonight's just following on from our previous session. So I think for me, where I work with a lot of clinics, I usually see a lot of opportunity. And where we are thinking we're doing really well when we actually pull some reporting and look at those numbers, a lot of the times it doesn't match up with the work that we're doing. So lots of ways that we can kind of look and improve on that. And some are just tightening up some of the processes, especially around billing. So I just want to shine a torch on some of the MBS item numbers and categories that you might not be using at all, especially around case conferences and things like that. Some of the other potential opportunities for revenue streams, especially utilising your nursing workforce on behalf of the GP item numbers, especially around some of the telehealth and phone options that the nurses will have as well on the ground. So I think for me, it's going to be looking at what you have and how you're best going to be able to use that from a physical space and location to the team that you have working for you as well. So let's jump in and we'll have a little look to see how we can make things a bit easier and more financially sustainable. So overview of the Medicare and PIP. And I think a lot of people will always ask, around the different types of reporting, where you're going to get your different reports from. And myself, I like to look at a whole heap of different reports, especially if we're looking at, doing assessments and things with clinics. So you're going to have a lot of data. And, first place to start is the clinical software. So always asked to look at clinic's appointment book. I can tell a lot by what's happening in just the appointment book alone, from the attendance rates to, the incomplete appointments. And then when you look in some of the financials, you'll be able to see, held accounts and, the reconciling and things in the background. So a lot of things will impact, the revenue into the clinic and impact cash flow. So these are all very important things to kind of tighten up some of the processes. And we will talk about some of them today and some of them tomorrow night as well, especially around the end of day, end of week, end of month processes as well. We're going to have a look at the incentives. So for those that have been in practice for a little while, these incentives have, changed and changed name and, changed descriptions over the years as well. So I think it's a really good time while we're looking at all the other numbers to maybe just have another glance at what's included in the different incentives that are available, and triple check what you're registered for and things like that in the background, because that happens all the time as well. Oh, I thought we, registered for that one, and sometimes it just hadn't kind of got through to the point where it was actually active. So all of those things, there's nothing wrong with, double checking those at this point in time when we're doing an annual review. So definitely worth looking at. And then funding. So obviously if you're getting, different government grants and things like that, you'll be looking at some of those reports in the background to report against and things like that. And then the different programs that are available, obviously looking at, your patient registrations and things like that for My Medicare, etc. So I look at all the numbers, and it doesn't have to be, always financial. I'm interested in, especially the attendance rates and things like that when we talk about patient engagement. You might be using other third-party providers where you can have a look at some of the additional, reports that are available around your patient demographics and eligibility. I've just got an example there, like it's QECO. And then we really want to dig down into the financial side of it. So like we kind of mentioned last night in the planning session, it might be that clinics might want to separate and have their management team, maybe looking at, the financials and some of the other numbers in the background. But obviously, things like your profit and loss and, other revenue streams. And it's a really good time to look at the different expenses that might be coming out from the practice as well. So every report is kind of up for grabs, and everyone has a different lens that they're looking through. So if you're talking to, the nurse and, maybe some of the clinical team, they're usually looking at it from an appointment type and, we're always busy and things like that. Practice managers, office managers, owners, they're looking at it from, money in, money out. So we need to take that whole practice approach towards this as well. To kind of think about some of the processes and activities that we're doing that we could maybe adjust to kind of be more financially viable. So let's jump in and have a look. Now, obviously, our chronic condition item numbers changed over last year. There's been some changes around the health assessments as well. So this is where it's really important to pull your demographic data, and you'll see in the worksheets that we've got for tonight's reflection and tomorrow's as part of your planning process. It's really important to look at the demographic breakdown for those core activities that you're doing. So some of the big changes that you might not have, I guess, heard about is around the First Nations health assessment. So patients that have had a health check in that first 12 months, so that, as in like a 12-month snapshot, can also have a heart health assessment. There were some changes in the time-based or time-tiered health assessments as well. So patients are actually eligible to have more than one of those time-tiered health assessments in the 12-month period if they're eligible for those as well. So it's a really good time to jump back in and have a look and go, well, this is how many patients we have. This is how many items we've done against those different categories. And we've got those worksheets to help you work through those as well. There's still a lot of options for video conference around those item numbers. So I know some clinics are using those. The chronic condition management plans are still, video conference option, and the review, as well as the First Nations like health assessment as well. So lots of item numbers around the chronic condition management. I've got on the next slide the other medical practitioner items there as well, for those providers that are on or attending these sessions as well, so they can look. And then one of the most underutilized item numbers is usually the home medicine review. So I've got the one there for the patients in the community, but also the residents in aged care as well. So for me, this whole category can usually be, the performance can usually be a lot better, and improvements can be really simple, as in you know, for me, one of the most important processes that we do in our training and, you know, with admin especially, is getting the patient to book that next appointment. So whether your workflow includes, you know, the GP doing these care plans on their own, or whether it's more team-based and you have, you know, a combination of the nurse or health worker and GP completing these activities, the main goal for the patient, any patient walking out of your clinic, is to be booking that next appointment. And that just takes a whole lot of admin pressure off in the background. So it means that we don't actually have to kind of chase patients back into the clinic. We're getting them more engaged in their care, so they're coming back to the clinic for that next activity. And also, obviously, when we're doing, you know, our care plans and health checks, it's mapping that care for the 12 months. So usually when we do one of those bigger activities, a lot of patients can come back, you know, for about 4 to 5 appointments, usually from one of those assessments or care plans. So, you know, they might be overdue for a skin check or, you know, needing to come back in for spirometry. So all of that revenue flow from those bigger activities is obviously making your clinic more sustainable as well. So we just really want to make sure that, you know, we're looking at the workflow from when the patient, you know, how the patient gets to your clinic to start with, for some of these health assessments, etc., in the background, care plans and reviews. So the most common thing that we'll see, and I've got it in our example that we'll use tomorrow night, is that a lot of clinics are really good at getting the care plan completed. So if they've got target groups of, you know, call it 2,500, you know, your patients, they're usually really good at getting, you know, above, you know, 75% target rate on those. But when we look at the reviews, not so much. So they're usually under 50% of our target. And that's assuming that the patient has 2 care plan reviews in that 12 months. So, you know, it's an underestimate, but a lot of clinics will still underperform with those numbers as well. So that's what I mean. It's time to look at some of those processes that may be impacting, and you'll do that with what's working well and what's not working well. And usually the things that are working well have a really good process. It's not that you're better at doing them or anything like that. It's just that you have an established, you know, process that's actually working. So all right, let's jump in. So we've got our other medical practitioner item numbers as well. So I'm not going to stop on that, but you've got it for reference when you do your reporting in the background as well. All right, we're going to jump into our nurse, Aboriginal health practitioner and Aboriginal health worker MBS items. So a lot of these items are on behalf of the GP. The main, I think, things that I see, especially, you know, post-COVID, we still have the phone and video conference options available. So these sets of numbers that are available are very underutilized when I look at the reporting in the background. So obviously the video conference might not be suitable for every patient, you know, that we're seeing after a care plan or a health check. For the Aboriginal and Torres Strait Islanders, but definitely the phone one, I find it's a really good option for the in-between appointments. So if I'm seeing a patient and it's, you know, something as part of their care plan and I need to follow up with them, you know, do I need to do that face-to-face is going to be my main question. So when we're talking about how we can, you know, improve the, you know, workflows and revenue streams for those clinics that are really limited with space, you know, those options of, you know, the hot desk and things like that, we might have, you know, multiple terminals and, you know, phones and a basic setup. So some of your providers can actually deliver some of those phone or, you know, video conference items. So it's something to really consider. Because they're available now in, you know, multiple. So when we talk about case conferences, you know, GPs participating in that don't need to be face-to-face. You know, they can be dialing in for those as well. If you've got allied health providers at your clinic, you know, providing those services as well. So lots of options of how we can actually deliver that in-between care. And for me, that keeps the patient engaged as well. You know, it might be, you know, catching up and checking on a blood pressure or, you know, doing something in between around, you know, their appointments and things. But I know those clinics that are doing, you know, the DVA and CVC program, they're already used to kind of doing these follow-ups in between by phone. And I think it's, you know, time that we worked in our regular patients. So these numbers are still active, they still exist, they still count towards the 5 and 10. So 5 under the follow-up under the care plan and 10 under the follow-up under the 715 health check. So definitely have a look to see how many of these you might have billed, but I guarantee it is one set of numbers that you'll probably not have billed. And it's very rare that I'll see every single patient. So when we look at the numbers tomorrow night, if you have, your cohort of patients that are eligible for a care plan, and that even have had a care plan completed, it's very rare that I see, 5 of those completed in that 12 months for follow-up. So it's definitely revenue that's left sitting on the table. And it's not for the fact that we're not doing it. And that's where, things like the tech shortcuts and things for your team. Because if you're like me, I can't remember all these different item numbers now. So my tech shortcut for the 10997 also includes the 93201 item number in that description and the 93203. And that's so when I'm, using that item number and tech shortcut, it means that I don't have to, look it up or, try and chase down an item number that I, can't remember for what the phone version of that is. So, making our jobs a little bit easier and having those in your autofills and things really makes a difference of whether those item numbers are going to be claimed or not. And then I guess for me, the other process that is really, really different from clinic to clinic is the finalising of that visit. So there's usually a couple of challenges, and it's how we're actually going to communicate with admin without walking a patient out and without ringing admin, because they really don't want to hear our voice 5,000 times a day. So how can we, communicate better as a team to kind of get that in? So for me, for using, best practice, you want to make sure that your nurses have that option to finalise the visit, because we can do 2 things in there. We can put the item numbers that we've used, but we can also put, what appointment the patient might need to book in next. And you want that from every provider, whether it's a GP, allied health in your clinic. Every single patient coming through that door needs to come back, especially those chronic condition patients. It is really rare that you would say, okay, see you in 6 months. A lot of those patients need to come back, for those regular planned visits. So those processes around the finalising of the visit is where a lot of the money just doesn't get claimed. So they're performing the activity, they're doing that with the patient, but a lot of the times those numbers just, don't make it through to the other side of and getting into the batch to be claimed. So yeah, just something to think about for the end of patient journey. Not end of patient visit journey, I should say. That sounded like a bit morbid for this time of night. Okay, so our other item numbers, and obviously usually your nurses in, treatment room and things like that are accessing these activities, and they're being billed under the provider. So same thing, any of these item numbers that are really common, that are being, completed by usually the nurses or health workers in as part of a treatment room visit. I have a tech shortcut for every single one of these items, because I can't remember, there's criteria around each of these item numbers that we need to make sure we're, completing as part of that. So a lot of the times people won't bill because they're not quite sure they've completed enough to bill that item number. So I think let's take the guesswork out. Let's get some tech shortcuts set up around each of these particular item numbers. And you might have additional ones that, are being used at your clinic. I've just got the main ones that kind of count towards a lot of the CDM follow-ups in the background. So having those tech shortcuts and the item number there means that if I was the nurse seeing the patient and we'd, completed whether it was Spiro or, ECG in the background, I can use the tech shortcut that I've got, make sure I've completed everything for that, and then it's for the GP to sign off and finalise that on their end as well. But I've, popped that when I finalise the visit. So yeah, it's usually money that's the activity's been completed, like the other nurse item numbers, but a lot of the times they won't get finalised, and it's more from the confidence level that, on completion, that they're not quite sure if they've done everything under there. I think the biggest category for me outside of the care plan and review that the GPs usually are missing out on a lot of income is around the mental health item numbers. There's so many item numbers over the last 12, 18 months. Like I've never seen so many numbers, kind of attaching into the one category. So I've got the main ones up there. I know we lost the, review and consult numbers. And I think this is something to think about. A lot of clinics would have already had an appointment type for the mental health treatment plan review. If you don't, I'd probably think about getting one. So, because obviously if you are seeing the patient for their mental health treatment plan, you really want them to book for the review. And I don't care if it's in the 4 weeks, if it's in 3 months or 6 months, but you really want that patient to book in. And so I find that the reviews for the mental health treatment plan, even when there was an item number, it rarely got billed. And so I find that if we just book it as a consult number, and I know it's going to be billed as a consult number, but if we book it as just a consult and there's no kind of appointment type or description in that, when the patient turns up, that sometimes they can't remember why they're there. The GP's got 20 other patients booked in, and they might not actually complete the review at all. So it's just something to kind of think about with some of those changes that have taken place as well. And obviously any of the other activities, whether it's a video conference, phone, if that makes it easier to kind of book and separate those as different appointment types as well. There's a whole heap of case conference numbers that were released under mental health as well, but I've kept that as a separate category. But, you can see there's so many options. We've got the eating disorder treatment plans as well, and the focus psychological strategies. So lots of things that can, I guess, go towards that category. And so when we look at how many patients qualify for a mental health treatment plan versus the number of patients for the chronic condition management plan, I find the models of care work better if we keep the nurses on the chronic condition management and we have the GPs, focused on the mental health. That way we can kind of bring both categories up at the same time. So obviously that's going to depend on, workforce and things in the background. But yeah, it's definitely an area that's underperformed, especially around the review. And same thing, we want any of these items to have that text shortcut to make it easier for the GPs. For any of you guys that have access to our, templates in the, portal through the PHN as well, you have access to our mental health resources, including templates and text shortcuts in there as well. So our template's been updated, so there's not a lot of, double typing in the background. It makes your job a little bit easier to actually complete those as well. So I've got the OMP mental health item numbers as well. And then we're going to jump in and have a look at case conferences. Now, I feel like this is one category that clinics are either doing and they've done for a long time. So especially a lot of the art shows that I work with will have a lot of these processes, set up, especially under different categories like maternal and some of the more complex patients. But I find a lot of mainstream practices aren't usually doing a lot of these. And I think it's something that we can definitely do a lot better and think about I think the different pathways where we have internal case conferences, which is usually an afternoon that we've set aside, maybe once a week, once a fortnight, once a month. And it's an hour that we usually set aside. We usually do it in a GP's room if it's just an internal team and we need the GP and 2 other providers in there. So the really good thing is that Allied Health can now bill an item number as well. Nurses can be part of those and count as a person, but they can't bill under there. But the GPs that are organising and coordinating, and then the GPs that are participating can also bill in there. So obviously specialists and things like that. And, these, we've got various modes of delivery. So, no one has to be there. Everyone doesn't have to be there face to face. The patient doesn't have to be there if they don't want to either. So usually when we're putting that care plan together, if it's one of those more complex patients, usually I have that conversation with the patient and explain, what that might look like. So if it's an internal one, the patient's consented, we've explained the process of what that looks like. And usually it's, very simple. I've never had a patient kind of refuse to either be part of one or for us to hold one on their behalf. But usually it's because they've got multiple providers involved. So I'll just kind of say, we've, because of, everyone that's involved with your care with your diabetes, are you okay if we, catch up and have a chat to see what we're going to do about your feed or your medication or, whatever it might be is that main issue. And, we've documented that in there as well. And the GP will usually contact them, the organiser after those with the, feedback after the session. So really, really useful, I think, as a team, especially for our more complex patients. So the internal ones work really well. You block an hour out and you can kind of go through about 5 if you're doing the kind of short numbers. They're all time-based. Same thing. We've got really good tech shortcuts, really good templates for you to be able to kind of just jump in and kind of do those as a process. So the internal ones are planned ahead. You've got an appointment type, you've got them booked in, and they're just your team. Maybe some external providers, but usually not the patient. So if it was the patient going to be involved, and I have been part of lots of those as well, usually it's a lot of our, more terminal patients and things going on, a lot of, complex social things as well. So usually they'll have family, patient, lots of external providers. We would book that like we would a normal appointment. So you might want to leave those towards end of session, like before lunch or, straight after lunch or something like that. Just sometimes they go like a little bit over, but you would book it as you would a normal appointment across whoever you need to be part of that from your internal team. But yeah, they can work so good. If you've got internal allied health providers, inviting them to be part of, your internal case conferences, make it so much easier to kind of nut out all those issues instead of, emails back and forth and, internal messages and things like that. And same thing, if we do a case conference today, we will book that patient in one of our next case conference slots. So if we're doing ours, once a month as an example, we'll book it in, for 3 months' time or, months' time, whenever we need to kind of catch back up, depending on, the urgency of it. So it's really important to, I think, consider this as an option, just because it's something that we can easily work into our day. And I find that a lot of clinics are already doing this. They just don't, there's no formal process around it. So usually we'll have a conversation and then catch up. I might have seen the patient, have a chat with the doctor. We're all kind of talking about the patient's care and what might need to be done. We formalise that process and make it, part of our internal case conference structure. It just means that we can actually claim for that time that we're taking to put, further plans and actions in place. So yeah, they can work really, really well. For those teams that have got nurse practitioners involved in their clinic, that might be as part of their clinic, their numbers keep expanding as well. I was really excited to see that they'd released a case conference item number for them as well. The year before, there was a nurse practitioner point of care testing item as well. So lots of ways that we can actually include them as part of that long-term care and management as well for our complex patients. There was just one other number, so I'm just going to go back to the nurse one. I just wanted to mention the original telehealth number. So the 10983, this little one in the middle, this is for a nurse, Aboriginal health worker or practitioner, and it's if they're providing that end support service for the patient that is doing a video conference with a specialist. So I know a lot of people that have been around a long time. This number came out in 2014. I feel very old when I talk about this number, but this is the original telehealth number. So there are clinics that have really good setups where they can actually have a full appointment list of patients that are coming in. We can allocate a nurse, health worker or health practitioner to that list, and they're sitting there with the patient as part of those specialist appointments. So think about how that can possibly run. Sometimes we might do the follow-up number and service as part of that before we might actually take part into that case conference. But financially, that 10983 is actually quite good as a service. So sorry, I just wanted to mention that before we jump into the practice payments. But yeah, definitely worth having a look at. And then for those clinics that have the AHPs, Aboriginal Health Practitioners, depending on your state territory like requirements. There's also an immunisation number and then the treatment of the wound. So same thing, we have our text shortcuts for those because there is criteria around those. For example, the treatment of the wound, it has to be seen by the GP on that first visit, and then the subsequent visits can be without instruction, but it's so they can assess and instruct on what they want done with that wound. So yeah, there's great options to kind of expand your roles of your nursing team and health workers in the background. All right, let's jump into the practice incentives. Now, this is something that I said it's just worth going back and having a look to make sure. I know it sounds silly if you go, oh no, we're registered for that. I just want you to go back and double check that number one, you are registered for the ones that you qualify for. There's been some changes all around, I think, when I kind of go back into guidelines and have a look at the beginning of the year. There's been quite a few little updates. So for those clinics that have and taking part in the Indigenous Health Incentive, there's been the changes around there. Obviously, we've known about those for a little while, but it's at the point where there's the registration payments are no longer there, and we're working on outcome payments. So revising and maybe updating the team to make sure everyone understands what you need to actually receive both those payments. So if we're not completing our care plans reviews, health checks for those patients over that 12-month period, we're not really going to reach the outcome levels. And that is a lot of money to leave behind, especially when I'm looking at ACCHOs. You might have smaller populations in your clinics of Aboriginal and Torres Strait Islanders, but just keep in mind the outcome payments is, on top of what we're getting for the Medicare activity. So really important if we can reach those. The quality improvement incentive, I think this is one that can, really help, streamline some of those projects that you're looking at, with the payments that you get for those in the background. So I really like being involved in any of the QI activities in the background. And then obviously we've got our capacity stream, so after hours, e-health and teaching payments. And then we've got the rural support, so the procedural and rural loading. So go through, make sure you're registered with what you can be registered in and up to date with everything. And then when we're talking about cash flow and things in the next part of tonight's session, this is something that you need to, consider when you're mapping when the money is going to be hitting your bank account, because usually it's not till the end of that month. So sometimes we might roll that if we're, predicting income for cash flow into the next month, especially if it's meant to be coming in that last part of the month. We usually flag it to, maybe jump into, the first payment as an example in February. You might roll it to be March. As an example, because it won't be in your kind of cash flow until that next month. So really important to try and predict where you can, what you're actually eligible for as well. But go back and have a look at the last 12 months, of reports when you were doing the other reflection activities. You really want to see, how you've performed, because same thing, until we see it in action and what we've actually qualified for and what we actually have received, you just want to make sure that you're actually getting what you are able to get. You really want to make sure you're actually accessing all of those funds. The workforce incentive programs, same thing. We want to make sure, obviously, like some of those payments, the doctor and rural advance will go to the GP, but for the practice stream, we've got 3 quarterly payments, or 2 quarterly and 1 annual DVA loading payment in there. So we want to make sure that we're actually kind of hitting all of those payments and targets if possible. And same thing when we're mapping our cash flow, we just want to make sure we're mapping it to where it's going to land in the bank account for those purposes. So the bulk bill, aged care incentives as well, just make sure we've got those mapped against where they're going to land in your account as well. So I've got underutilised revenue as our next little category. And I think this is the little reflection activity to carry on. So if you're going to do this separately with the team, or, you'll break up your team to kind of look at the finances. So this might be your, management team doing this in the background. when the actual, numbers get plugged in the background. But, think about them as categories. I think this makes it easier for when we decide how we're going to pull our reports month on month, to see, our improvement and things in the background. So what does that look like for chronic disease management? So what are you actually going to count in those item numbers? Usually I count the core activities. I'll map the nurse on behalf numbers separately. That's my preference, just so I can track the different teams in the background. But usually I'll count it as one big blob of, chronic disease revenue altogether. But I like to categorize across. So have a look at those items that we have in the slides, and see, you can even just highlight those ones that you kind of see through your reports. You'll see the gaps of the ones that you aren't billing, and then see if there's a way that you can adjust your workflows to include them as well. Obviously if you don't have a nurse practitioner, you won't do that. If you don't service aged care, etc. I've got skin and procedures as a category as well. So there's lots of item numbers under that. I've worked in clinics, we've had quite large numbers of doctors, large number of skin clinics that we have running during the week as well. So there's a lot of billing in the background, a lot of consumables, a lot of things to kind of cost into those procedures as well. And then depending on the specialties involved, they may be able to contribute to a care plan as well under that 729. So have a look at the different pathways that are available around some of the specialist involvement that you may have. Telehealth, really big one as well. And lots of opportunity because we don't need a consult room to kind of run some of those items in the background. So that's really important for those clinics that are really space poor in the layouts of their consult rooms and things. So it is a great way to kind of add in additional revenue without necessarily, the expense of, face-to-face visits or home visits, etc. in the background. Allied health and specialists. So obviously, depending on the clinic you're running and how those providers are there, it may be as an income stream for renting the room, or it might be as part of, like, say, some of the ACCHOs and other funded clinics. It might be that you're accepting the Medicare revenue as part of that, or a split arrangement, etc. So there's lots of ways to kind of see that in the background as well. So part one is to complete that, just to kind of flag which categories you're using. You might be accessing some of those numbers, so just highlight those ones that you aren't next to it, and you'll see those more in your reports when they come through. And then I think it's really important to reflect on what is working well. So example would be, some clinics are saying, we actually do our chronic disease management really well, but we might not do case conferences as an example. So, why does the chronic disease management work well in their clinic? So it's a lot of those processes that are in place that you may be able to replicate and, add another category without so much of an upheaval in the clinic and, putting in a brand new process. So a lot of the processes can be replicated, especially when we look at, how the patient gets to the clinic, next appointment, finalising the visit. So a lot of the processes will end up being the same. So having a look at what's working is really important. And then also looking at what's challenging. So, lots of examples. Each clinic's really different. When they flag to me what are some of the challenges they might be having in the background. So don't feel that's a bad thing that you're writing something there. I think recognizing what you do well and what you don't do well is the best thing that you can do for your clinic, because it means there's something we can improve on and potentially add additional revenue to your clinic. So I don't see that as a negative. We just need to recognize what might be a bit harder for us to complete, and it might be due to things like workforce, etc. in the background, or it might be something brand new that we've never done before, and so we're a bit hesitant of trying that in the background. Case conferences is usually one of the ones that clinics flag to me. They're a bit nervous about doing it, they haven't done it before. There's a bit of coordination to kind of take place in the background. So once we've got a process that works, we can usually expand it to include other categories as well. Check out the incentives that you are accessing and ones that you might not be. So when you have a look through, just make any notes of ones that you might be able to access or add into the ones that you're currently doing, especially the bulk bill and aged care as well. So make sure you're looking at every single aspect of the clinic. What workforce incentives you're accessing in the background. And then the last one I've got before the big action list is the underutilized revenue. So what are some of the like MBS item categories that could become an opportunity for your clinic without too much of a stretch? So those ones that have processes that are very similar, you might be able to just add an additional one without too much work. And then other income categories that could be future fit. You know, think about lots of things you might have heard other clinics doing. You might be like, oh, we did talk about that a while ago, and we haven't kind of looked at it since. So there'll be other things like medicals, and I find that work cover is it's not an MBS category. Like, of course, it's but under work cover, I find a lot of clinics do not bill this properly at all, and they're underutilizing that revenue. So especially for that initial consult and things, and then all the consumables and costs against it. So if you do have access to our portal, we've got a really good work cover billing sheet. And I know a lot of the doctors just like to have that in the room, and especially if we don't have, claim number and things to start with in the background. But same thing, can't remember every item number. I just need to be able to grab it. So text shortcut or billing sheet, however you want to access it. But just make sure that the GPs are especially aware of what could, potentially go in there. You might have a spare couple of rooms at your clinic and, difficulty getting access to, regular workforce. You might consider, renting that out to, other providers that might be able to see patients at your clinic. So lots of different ways that you can work with your clinic to see, what's available and what else we can add in. So that value add and income. And then, were there any, practice or workforce incentives that, could be an opportunity for your clinic? And it doesn't have to be today, it's going to be part of this 12-month plan. So it might be that you flag that, you could potentially, do this, and part of that 12-month plan will be, putting steps to complete it in there and make it part of your revenue stream. So our action list for today's session is to organise that planning day with your team. Obviously, it might be a couple of different team members depending on the clinic setup looking at these, but trying to define what your categories are really important, especially around the chronic condition management. So whether you want to kind of keep all the nurse numbers, nurse or health practitioner and worker numbers all together. As an example, I split the mental health case conferencing into case conferencing and not mental health when I'm doing the reporting. So just defining, what your categories look like as a clinic. And that will just mean when we're, getting that revenue number in the background, I really like to do a baseline assessment. So we're going to have a look at that in tomorrow night's session about what you might want to include in that. But in simple mathematics, I prefer to, grab all those item numbers into the category. And I'll have, chronic condition management, if I call it that, as my category. We run the report on those, certain categories and item numbers that we've included in that. And we'll come up with our baseline revenue. So what did that number look like over the previous 12 months? And then we'll turn it into a monthly average. And then every month we're working against that average. So we really want to make sure that we're, improving month on month against that category. So for clinics that just want something really simple, defining what goes in your chronic condition revenue is probably the easiest. There'll be really big clinics that want to kind of go down into the kind of minor categories to see how their different teams might be performing under those. But for the simplistic one, I would just look at it from the CDM revenue and the items you want to include in that. And then when you look at reviewing your underutilized revenue as a team, you really want to vote like we did ready for our next session tomorrow night. You want to vote on the top 3 priorities that you can find from that list that you put together. So from that section 5, so just back in this one, you're going to vote with your team for the top 3, and you're going to put it together in tomorrow night's planning session. So that will give you your roadmap of priorities of where you're going to kind of put your effort over the next 12 months. The top tips for tonight I've just put as ways to improve the cash flow. And I've seen lots of different ways that this will kind of come around as well. But for me, the biggest thing that we can do is design the care first with the team that we've got, and then we're actually going to map what that looks like. So, if you're looking at each visit and, what's going to come through to the clinic at what time, then you really want to make sure that we're mapping it in those orders as well. So, if we were running a weight loss clinic as an example, what did I expect to happen on, visit 1, how patient's going to kind of be referred into that in the background, what's the nurse going to bill when they see them, what allied health pathways do we have, what's the GP going to bill, when are we going to do the care plan and things. So all of that care is really, really important, because we actually want to make sure that we're getting that income against those models. So really, really important step that we can't miss. You can't miss it, because you'll kind of miss out on that income in the background. So the next top tip that I had was, defining those income categories. A lot of the roles I've had previously, in practices, whether it was, mainstream or archers, I had a lot of KPIs against my roles. So when we're talking about improving processes and, chronic condition management, like as a whole, I had KPIs against, certain MBS categories and things. So I think defining those income categories makes it easier to break that down into a target for your team. And I prefer a financial target per day, per week, per month, if we're working towards that, because it's really hard to say we're going to do 2 care plans today, 2 every day, and 2 health assessments every day, because it's really hard to kind of reach some of those targets when it's per activity, and your team will lose momentum and the incentive around it. So yeah, myself, if you're going to set income, KPIs and KPIs against what you're trying to improve, then myself, I prefer to see a financial target that we're working to each month. So yeah, defining those categories are going to be really important, because it's going to be very clear to the team what item numbers are included in that category. And so they have an idea of, where they are and if they're on track. So really, really important. And then the third dot point was just around reviewing the end-to-end process. And it might sound silly, but, mapping that patient journey from, from billing to the next appointment and claiming, what happens in your clinic after that. So, who's responsible, who's doing that role of, submitting the claims, reconciling. And the reconciling is a very big job. There's over 200 different error codes that can come back. And so it's really important that when we get those rejections back, we're checking that we've got the right notations in and things in the background. So it's something that, obviously should be resubmitted if possible, but that's where training with admin is super important when they're finalising those visits, especially in the background. And then I can't stress how important the end of day, week and month processes are to your bottom line. If we're getting to usually what we would do end of day, we check all of our appointments. So every appointment has to be, completed or, did not attend. And then when we're submitting those batches through, usually we'll have, people running out, adding extra items, they've been forgotten and things like that. So it's everyone's responsibility as part of that patient journey for the Medicare side of things in the background. For me, it's not just the GP. Myself as the nurse, I'm actually contributing to a lot of those numbers in the background. So me putting my text shortcut in, making sure I'm doing everything so the GP can complete that item number is really, really important. So those processes in the background can really impact the bottom line. And then things, about the end of week, end of month will be around held accounts and, overdue accounts and things in the background. So tightening up some of those processes can really impact your cash flow. That's it from me. So I'm going to introduce Vadia. So she's the coordinator quality improvement for quality improvement and reform for Brisbane North PHN. So in her role, she leads initiatives that support general practice capability, system improvement, including the sustainability project, which is focused on strengthening practice viability and tailoring PHN supports across the region. So while Buddy is talking, I'll have a look at the questions in the background as well, and then we'll have time to have a quick look at those tonight. If we don't, I'll send them through in an email as an answer as well.
Thank you, Jane, for the introduction and the fantastic presentation as always. Really practical and a segue to some of the work that we've been doing at Brisbane North PHN around practice sustainability. And now for those who were here last night, this may sound familiar, and apologies for the repetition, but we're delivering the same sort of messaging across these 3 evenings to make sure that each session stands on its own for anyone who's joining for the first time. So reiterating that you are not alone in this journey, and the issue of practice viability and sustainability has been on our radar for some time now, but it became much more pressing over the past year, particularly when we had a lot of practice closures and mergers happening across the region. And we know that the practices are facing real pressures, as discussed earlier, whether it be workforce shortages, financial strains, rising operating costs, and operational challenges, all while they're trying to deliver high quality care. So we took a step back and asked ourselves, how can we better support our practices to take charge of their sustainability and not just reacting to the challenges as they arise, but proactively strengthening and future-proofing their business. So as part of that, we looked nationally at what other PHNs are doing, what tools they're using, and what support models they've put in place. What has stood out was the importance of tailored practical support and a data-driven approach, and clearly not a one-size-fits-all solution. Practices are under pressure in different ways, and support needs to reflect that, which requires us to assess how each of the practices are doing and what issues they're facing. And this brings us to the aim of the project, which is simple, to give practices clear insight into where they're doing well, where they might need more support, and to help them actively work on strengthening and sustaining their practice. Each practice has a different starting point, and we would like to recognize that in the process. So therefore, as a result, Brisbane North PHN is introducing Practice Catalyst, a short 25-minute self-assessment tool designed to help practices identify their strengths, pressure points, and priorities across areas such as governance, workforce, operations, and sustainability. After completing the assessment, practices receive a customized self-paced action plan or practice development plan, which outlines practical next steps and provides relevant resources. The PHN receives aggregated data, not individual practice details, which allows us to better tailor support where it's most needed. So just to highlight what this tool is and what isn't, first and foremost, this is a self-assessment tool, not a survey. It's something your practice completes for your own reflection and planning. And it's also not about performance or compliance. There are no scores being shared, and it's not an audit. The purpose is to help practices step back, reflect, and plan in a structured way. It is confidential, and from the PHN perspective, we see aggregated data to help us tailor our support to meet those specific needs. It can be done by the practice manager or leadership team, whoever is best placed to reflect on the operational and sustainability aspects of the practice. The intent is to make this practical, low burden, and a genuinely useful exercise, something that gives your practice clarity and direction rather than creating extra work. So what's next? We're currently working with our external provider to implement this, and information on how to access the tool will be coming to your practice soon via email and other communication channels. And that was all from me. Thank you.
I had a quick look in, thanks, Buddy. I had a quick look in the questions. I couldn't see anything there. So if we don't get
I
any
think we have
questions through tonight-
one
one's jumped in.
comment slash question. We have one participant asking us if there's any information regarding opportunistic multi-billing.
Multi-billing, yeah.
Because it would be useful to have some information regarding that.
Yeah, if you have access to the Brisbane North corporate portal, you'll have our billing combinations and some really common examples in there. But I'm happy to send a couple links through to Julio that he can, distribute as part of the follow-up from this as well.
Thank you, Jane. And just as a reminder, the corporate portal is the portal that some of the practices had access by participating in one of the QI projects. We reach out to our team to see if we can share some of those access to you guys. The important thing to remember here is that you are not alone. We obviously, as a PHN, want you to be successful, and that's one of our main I guess focuses, at least for the near future. So please reach out if there's any other questions. I guess we can give our participants a minute or so if they want to ask any other questions. If you have any burning questions, please do ask. We'll get to that question. Sorry, Jay?
And I was just going to remind everyone, tomorrow night's session is really exciting. You're going to see how we can get almost $1 million without even trying too hard. So it's not the lotto draw tomorrow night. It is our third session. So what to do next. So putting that plan into place. So really exciting. Really want you to jump on there and have a look at that if you can, and take that back to your clinics and implement. So really easy ways that you can get that additional revenue happening with some processes.
Okay, well, thank you so much, Jane. I don't see any other questions coming through. Thank you, Jane and Badia, for such practical and insightful session this evening. And thank you everyone else who has joined today for the second session of this series. We know how complex the funding environment can feel, and we hope tonight's discussions have helped clarify where the opportunities lie. Not just understanding reform, but also actively leveraging it to strengthen your practice's financial sustainability. So we cover a lot this evening, from Medicare and PIP optimization to identifying underutilized billing opportunities and diversifying revenue streams. These are important levers that you can make a real difference in your cash flow and long-term viability. And we also kind of saw a little bit of a really exciting project that is coming to you guys, which is the Catalyst project. As a reminder, this session has been recorded and we'll be sharing with the registered participants in the coming weeks the slide deck, all the exercises that we've gone through, any questions that we've been through. We'll also send that information through to you guys as well. And also, as a reminder, there's a survey popping up at the end of the session when we close it. Please help us answer that survey. This is a way that you can tell us what you want to know, what type of information is missing for you guys. So it is really important for us for you to answer that survey. So we're looking forward to seeing you in tomorrow's session. We're having some really interesting content coming tomorrow. So hopefully we'll see you tomorrow night. So thank you again and have a great evening, everyone. Have a great night. Thank you so much.
Thanks, guys.
Thank you.
See you later.